Hello and welcome to our latest panel discussion from the Underwood Center of Digestive Disorders. I'm Dr. Osama Gaber. I'm the co-director of the Underwood Center and the Carolyn and F. John Bookout Chair of Surgery and the chairman of the Department of Surgery at Houston Methodist Hospital.
My name is Eamonn Quigley. I'm the chief of gastroenterology and hepatology, and with Dr. Gaber, I am the co-chair of the Underwood Center for Digestive Health here at Houston Methodist Hospital. It's a great pleasure to have you with us today when we're going to tackle a very challenging but very important topic, namely the pancreas. We will deal with pancreatitis and pancreatic cancer and other conditions related to the pancreas. To accomplish this, I'm delighted to have with me today a panel of true experts from Houston Methodist Hospital. These individuals have dedicated their clinical and research careers to studying various aspects of the pancreas, and I'm now going to ask them to introduce themselves.
Hi, I'm Dr. Sunil Dacha. I am an advanced endoscopist at Houston Methodist and director of Advanced Endoscopy. And I have a clinical appointment with Weill Cornell Medicine. I'm a clinical associate professor of medicine.
Hi, my name is Ashish Saharia. I'm a hepatobiliary and transplant surgeon. I am an associate professor in surgery, and I have an endowment from the chair of endowed chair from the Underwood Center.
Hi, I'm Main Abdurrahim, a professor of medicine, chief of GI medical oncology, and medical director for KRAS Center for Advanced Therapeutic Phase 1 program.
So let's get right into it. And Sunil, I'm going to turn to you to give us a little bit of background on the prevalence of pancreatitis, any changes or trends in prevalence of pancreatitis in the general community.
Right. It's an interesting topic. If you look at the incidence of acute pancreatitis, it's been around 4.5 to 35 patients per 100,000 population that's been reported. But the interesting and the concerning part is there is a significant rise in the incidence of acute pancreatitis. As we all know, one of the most common causes for acute pancreatitis is gallstones. And with the epidemic of obesity, we are seeing more and more gallstones and consequently more acute gallstone pancreatitis. So, and the other part that we know is that alcohol is the second most common cause for pancreatitis. But as we know that the incidence of adult population consuming alcohol is decreasing over the decades. However, it is not clear if that has decreased the incidence of pancreatitis per se. And smoking, which was never really thought of as a cause for pancreatitis, it is a real cause for pancreatitis, and especially when combined with alcohol, it is synergistic.
You know, the other category that we often talk about and we always worry about is drug-induced pancreatitis. Can you just give us some idea of some of the drugs that may cause pancreatitis?
Right. So when we are talking about drug-induced pancreatitis, we usually divide them into certain subclasses, class 1, 2, 3, and 4, based on how they cause pancreatitis. For example, if you take class 1, the prior HIV medications were known to cause pancreatitis, something like another antiparasitic like pentamidine, lisinopril. There's a lot of other antibiotics that are class 1, meaning that if it causes pancreatitis, it is an established cause and we don't use it again. And class 2, 3, 4, it is just based on the retrospective evidence, and you can always challenge with class 2 and 3 medicines, but never with the class 1 medications.
So in any patient coming into hospital, drug history remains very important.
Absolutely. That's one of the most common missed factors. In addition, as we know, there is a significantly increased use of GLP-1 medications and the other all new diabetes medications that can increase the risk of pancreatitis. And that's very, very important to counsel our patients about these medicines before we start them and report to the physicians if there is severe pain once they start the medication.
Dr. Gaber, I know you're my co-moderator, but I'm actually going to put you on the spot because I know you've done research on pancreatitis and in particular in the basic biochemistry and immunology of pancreatitis. Would you like to give us a summary of what that work led to and what the insights it's provided?
So pancreatitis is a really, to me, it was a very interesting disease as I started my surgical career because you had a localized disease of the pancreas. It was associated with some very significant systemic inflammation and actually could lead to mortality. And maybe those of you who are old enough can remember the Ranson's criteria, where things like PO2 and blood pressure were really determinants of mortality from pancreatitis. That took us to the lab to try to understand why that happens. And at the same time, there was some talk about the co-localization of zymogen granules in the pancreas and the release of the pancreatic enzymes intrapancreatically. And we really studied pancreatic macrophages, peritoneal macrophages, and were able to show that their stimulation causes the secretion of significant amounts of cytokines, and that these cytokines increase the permeability across the guts, caused endotoxin co-localization, appearance of cytokines again in the lung at higher amounts because of the amount of cytokines that came through the liver, endothelial cell injury in the lung, and then the manifestations of all the systemic manifestations of the pancreatitis. And that really gave us a pretty good idea of that the disease isn't just in the pancreas, that rapid intervention is very important, and the drugs that can ameliorate the pancreatitis by ameliorating the cytokine secretion, which has now sort of become ingrained into the treatment of pancreatitis.
And Sunil, getting back to you, how is this new information or newer information translated into the evaluation of the patient with pancreatitis or even prognostication?
With the more recent information that has been gathered, there is more and more talk about genetic causes of pancreatitis, and there is something missed features like medications like we talked about. And the more important thing that comes up often is pancreatic cancer that is not talked about and it's missed. In the genetic causes, there is some more new genetic mutations that have been identified that gives an insight into patients with recurrent acute pancreatitis. In the past, we would label them as idiopathic pancreatitis, but now we know that there is a root cause for that pancreatitis. And it's great Dr. Gaber mentioned about all this cytokine-mediated release that can cause pancreatitis and its complications. It's interesting, that's why we use indomethacin as a suppository to decrease the risk of post-ERCP pancreatitis. And it's also interesting that most of our transplant patients that get ERCP do not get pancreatitis because of the transplant medication suppressing the cytokine release.
So talking about complications, these of course are the dreaded aspects
Right,
of pancreatitis.
absolutely.
And would you like just to mention some of the complications of acute pancreatitis?
Right. So when you're talking about complications with pancreatitis, we usually like to talk to them about the local complications and systemic complications. And when we are talking about local complications, Atlanta classification is what talks about what we are talking about. Within the first 4 to 8 weeks, if there is interstitial pancreatitis, there would be what we call as acute fluid collections around the pancreas, and that which matures in 4 to 8 weeks into pancreatic pseudocyst. On the other side, the dreaded complication, if it's a necrotizing pancreatitis, it will evolve into an acute necrotic collection early on and then goes on to being a walled-off necrosis. In addition, the other concerning feature that we usually see is thromboembolism in the splenoportomesenteric blood vessels. And that has not shown to increase mortality or increase risk of bleeding when someone has started on anticoagulation. However, there is some data that if there's portal vein thrombosis, that portends worse mortality from pancreatitis. Now, when we're talking about systemic complications, within the first 2 weeks of acute pancreatitis, the most feared complications are multi-system organ failure, which is the most common cause of death. After the first 2 weeks, most of the complications are related to infection or sepsis of the fluid collections.
What is the overall prognosis for the patient who develops acute pancreatitis, and what factors determine that prognosis?
Right. So Atlanta classification really provides us how fast and how aggressively these complications progress. If it's an interstitial pancreatitis, most of the times patients do recover well without major complications. However, if there is a development of acute necrotizing pancreatitis with development of acute necrotic collections, that's where really the problem goes up. If someone has a necrotizing pancreatitis, the risk of mortality is around 5 to 15%. However, if there's an infection of that collection, the necrotizing pancreatitis, the mortality can go as high as 25 to 33%.
So from what you're saying, the initial imaging is very important.
Usually we do not emphasize on imaging as much in the early parts because most of the time acute pancreatitis, as we talk about the 3 cardinal signs of pancreatitis, classic epigastric pain radiating to the back, and then we talk about elevated lipase. And the most of the time, these are enough to do a diagnosis of acute pancreatitis. However, as we know, anybody that comes to the ER gets a CT scan these days. But the problem is that, as we all know, there is a significant third spacing in acute pancreatitis, and there is already a component of acute kidney injury from the prerenal component. If you're giving contrast on top of it, you're actually adding to the insult over here. So it is not required, but usually it is required in the next, like say, 24 to 48 hours, patients are not improving. Yes, it's important to do it at that point to find any other cause.
And what would be your preferred imaging modality at that time?
Actually, a CT of the abdomen with the contrast would be the ideal because it's quick and you can get the required information. However, if you're suspecting gallstone pancreatitis as a cause, then although CT is enough for initial diagnosis, usually want to get an MRCP to confirm if there's any cholelithiasis as a cause for acute pancreatitis.
So before we go to the surgical treatment, which is, I know we will discuss in a little bit, there is this widespread use now of GLP-1R, and pancreatitis is really prominent in that. Tell me about your experience with that. What do you see and how do you treat them? And
so in the GLP-1,
yeah.
So we've seen a decent amount, I would say, but we really don't know the exact incidence because data is all over the place. I think we will be knowing it in the near future. The one interesting thing about drug-induced pancreatitis is usually they're not really severe episodes of pancreatitis. I can tell you from so many years, I've seen only one patient with necrotizing pancreatitis from a drug-induced case. But usually they tend to be not so severe and self-resolving once you stop the medicine. And the key cardinal rules that we take care of in any patient's acute pancreatitis is fluid resuscitation appropriately, not to overload them, to minimize any unnecessary imaging or contrast for antibiotics, and early initiation of enteral feeding is very, very important to minimize any infectious complications. So we follow the same principles like with any other case of acute pancreatitis.
I want you to say a little bit more about the resuscitation because I think the pendulum has swung a little bit here. There was a stage when you were expected to drown people, literally.
Fluid overload, yeah.
Fluid, yeah.
Fluid.
So the fountain trial we're talking about is, so most of the data for this comes from Europe actually, because they have like a very well organized pancreatic, the Dutch group actually does a lot of these studies. So they've shown that a restricted approach is actually good enough because if you're giving a lot of fluids, you tend to cause volume overload, which itself has its own problems like pleural effusions, and then there's a lot of ascites and the retroperitoneal collection. So what we usually do is we tailor the fluid to the patient's needs. One of the important things to do is urine output. That's a simple thing to do. So you can tailor the approach to urine output, or if they're not making urine, watch for the bladder pressure. If it's going up, then you have to be cautious with the fluids. And always keep an eye on the pulmonary vasculature as well, because that's one of the first areas where you see fluid overload going into. So if you look at it, it's all over the place, but yes, we have to be cautious, but still fluid resuscitation is still very important. But we don't do that aggressive approach anymore.
Dr. Dacha, like when you talk about the drug-induced pancreatitis, we start using like more immunotherapy nowadays, like for almost all cancers. I treat GI cancers, and immunotherapy start making its way there. But when you see a patient coming with pancreatitis, might be like immunotherapy related, we try to treat it with steroid to shut down the immune system. But your management beyond steroid, as far as the fluid, resuscitation, and others, it's going to be the same, or do you do something different if it is immunotherapy induced?
So you're talking about the immune checkpoint inhibitor-induced pancreatitis. So most of the time, again, we stop the medicine. That's the first and foremost important thing. And the second thing is, yes, you give them steroids, obviously, but Most of the time, these are mild episodes of pancreatitis. We don't do aggressive fluid resuscitation. We do regular resuscitation, watching again the parameters of BUN, creatinine, urine output. Other important thing to watch for is hematocrit.
So it's almost similar
Almost similar. You would
management, but we added steroid because we try to shut down the immune system.
Yes, because that's a key thing about immune checkpoint inhibitors is steroids are the treatment.
And I think that the distinction is you shouldn't be aggressive resuscitation, but early resuscitation is
Yes.
important because we've done a study on like 30,000 patients in our hospital. And if you get acute kidney injury, whatever disease you're being, particularly in pancreatitis, but whatever disease you're being treated for, your mortality almost double. Yeah.
Exactly.
So the earlier resuscitation is really important. And the urine output is a great parameter to manage or to prevent the development of the acute kidney injury in pancreatitis. And the steroids shut down the immune system, but they also shut down the cytokine production from macrophages in pancreatitis, which is the mechanism that we talked about.
But you would restrict the use of steroids to this particular situation, not to acute pancreatitis.
No, not with other cases. This is only in this case.
This is the only indication for steroids, right?
And it was like going to be a slow taper. We try, like if it is a grade 2 or 3, taper it down to a grade 1, and then we start tapering down till you have like the pancreatitis resolved a little bit, so you can, because the goal is re-challenge with immunotherapy again, because it's life-saving. But at the same time, we want to make sure that these organs are protected from overactive or excited immune system. So I think it can be like short, maybe 4 weeks to 6 weeks roughly will be enough to put it into grade 1. But follow up with gastroenterologist team is always important.
So that's going to be my question to you, Dr. Abdul-Rahim, is that obviously these patients are on a checkpoint inhibitor for a very important reason, namely they've got cancer. So how uncomfortable do you become if somebody says, doctor comes along and says, this pancreatitis is caused by your drug, we've got to stop it. So
that's always a discussion actually, because we try to, immunotherapy is usually the first line if the patient is eligible for it, or sometimes can be second line depending on the type of cancer. But we try to, we said, okay, before stopping it, let's stop it for some time, give a steroid, re-challenge after maybe 4 to 6 weeks, with the plan that we are careful about, reinitiating or re-causing another pancreatitis. If the patient, some patients, they are really sensitive to immunotherapy, and that's they get a flare because we unleash the immune system. If we get infection, the immune system up 1 time. If we get immunotherapy, the immune system is up 1,000 times. So we can trigger the immune system, unleash it to cause pancreatitis, hepatitis, and other organs. But this is life-saving for some patients, and we try to de-escalate and maybe re-challenge them. But if they've proven that this is too much for them and they can't take it, and this is grade 3 or 4, then we said, okay, let's go for a second line or third line that is not immunotherapy-based treatment.
So you'd be happy with them stopping for 4 to 6 weeks and then re-challenging?
Yeah, because we stop the immune system, but the immune system might be tamping down a little bit, but the effect of the immune therapy on the cancer might lack lasting. It's different than chemotherapy. Chemotherapy acts within, and it can quick in. The immunotherapy, the benefit is the tail of the curve. So we give few cycles, and then we start seeing the benefit later on. So stopping it for months, which is usually a 1 cycle or 2 cycle of the immunotherapy, is not a problem as long we can use it for long term. That's the goal.
So I don't know much about the immune therapy pancreatitis. It's something new for me, but is it dose dependent? Like when you start, can you do smaller doses and build them back up again, or it's a all or none phenomena?
It's not the most common side effect of the immunotherapy, but we see it in some patients. It is not dose dependent because some patients, they get it the immunotherapy is dosed every 2 to 3 weeks or 4 weeks, depending on the type, and it's a fixed dose, for all comers. So some patients are really sensitive to it. Some patients, they actually undiagnosed autoimmune disease, and when you give immunotherapy, it's a flare-up. And then you start working up. Is it really like the immunotherapy or this undiagnosed autoimmune disease? But the dose-wise, it is all comers fixed dose.
Dr. Saharia, I know that there's a dictum in surgery that you keep away from the pancreas.
That's absolutely true.
My experience was that the last thing a surgeon wants to do is get involved in a patient with acute pancreatitis, but there are circumstances when surgery is required and indicated. So would you like to talk a little bit about those, please?
Yeah, when those indications are getting much fewer and far in between. So, as Sunil was saying, that the people with acute pancreatitis will develop fluid collections and pancreatic leaks. So when there are fluid collections and pancreatic leaks is when we will, and it becomes a mature collection, then we will think of doing some drainage procedures into the stomach or the intestine. That is typically what we will do in case of acute pancreatitis. But of course, let me just track back a little bit. But if it is etiology is gallstone pancreatitis, then our first dictum is to take out the gallbladder before the patient goes home.
Right.
So, and typically gallstone pancreatitis develops in people who have large-sized cystic ducts because stones can slip through and they pass through and they obstruct the sphincter, and sphincter obstruction results in pancreatitis. And of course, we need a combination of ERCP and then removal of the gallbladder.
So your recommendation would be, wherever possible, to do the cholecystectomy before discharge.
Before the patient gets home. Yes.
On the index admission.
Right.
Now, Dr. Gaber mentioned Dr. Ranson earlier. I actually remember hearing him speak. so I don't age too many of us. But talking about things that have changed, like autoimmune pancreatitis was unheard of when I was a medical student. But now we're seeing a lot of it. And you already mentioned it, that there may be an underlying autoimmune pancreatitis which will be triggered by a checkpoint inhibitor. And we unfortunately have seen cases where a patient had autoimmune pancreatitis actually had a Whipple for what was thought to be a cancer. And of course it wasn't. So I'd like both of you, perhaps Dr. Zaharia, first of all, to talk about when you're called in to see this case as a patient got a pancreatic mass. When do you begin to say, well, this might not be a cancer after all, this could be autoimmune pancreatitis?
Well, that happens usually when you see a head of pancreas mass and the person is not jaundiced and you're wondering what's going on, or the vasculature is not involved, and because typically you won't really see that in autoimmune versus cancers. Cancers will have a more invasive outlook, and there are of course exceptions. The IgG4 associated pancreatic masses can actually cause biliary obstruction also, but typically, pancreatic head mass, if it's a pancreatic cancer, will present with jaundice. And if it is pancreatitis that's affecting the mid part and the tail of the pancreas, and again, those are rare entities, I would say. If somebody has a mass in the body or tail of pancreas, the first thing, and it's an adult, especially if they're smokers, your first suspicion will go to pancreatic cancer. You will get an EUS biopsy. So you'll get biopsies done before we would prove anything, before we would call it autoimmune pancreatitis or IgG4 pancreatitis.
So you see quite a few of these cases,
Yes.
I know, because you presented them at our conferences. So what's your approach when you see somebody that you suspect might have autoimmune pancreatitis?
So autoimmune pancreatitis is two types, type 1 and type 2. For the sake of this discussion, we're talking about autoimmune pancreatitis presenting as a pancreatic mass. It's actually seen more in the Oriental population. That's why you see a lot of data coming out of Japan as opposed to coming from the US. But we have been seeing more and more autoimmune pancreatitis here now as well. And some of the indicators would be sometimes on the scans, you see a sausage-shaped pancreas, and there is some enhancement on the pancreas. So sometimes your radiologist will alert you that, hey, there's a possibility of autoimmune pancreatitis here, but not all the time. And sometimes you'll see like someone just presents with a obstructive jaundice, so suggesting of a pancreatic mass. So herein where the role comes in is we do the biopsy. Because if you look at some of the earliest surgeons, when they see something like this, they would take them to Whipple straight without a biopsy. And that's where some people have burned their fingers and retrospectively found out it was autoimmune pancreatitis. That's how all this has come into picture.
Yes.
Right. So currently we do what we call core biopsies to get a lot of tissue. And if it's autoimmune pancreatitis, you would see lymphoplasmacytic infiltration, that is IgG4 positive. And just having a serum IgG4 level high does not confirm that it's autoimmune. It's very important that we get a tissue diagnosis. And sometimes if you don't get an adequate sample, sometimes some pathologists and endoscopists push the limits, try to identify some lymphocytes, try to give some steroids, just only to push the patients into a DKA or a hyperosmotic coma. We've seen those cases.
Yeah.
So that's why it's important that you get good core samples, confirm with lymphoplasmacytic infiltration, IgG4 positive, or identify an adenocarcinoma, adenosquamous, or other type of carcinoma with precision, and then take the next steps.
We've touched on it a few times, but I guess we've got to say a little bit more detail about it, and that's pancreatic cancer. So you have spoken before about recent, really quite worrying trends in prevalence rates and demographics in terms of pancreatic cancer. Would you like to update us on that?
Yeah, that's true, Dr. Quigley. Unfortunately, the incidence of pancreatic cancer has been in the trending up for the last 2 decades, and unfortunately, we start seeing it in the younger patient, younger than 50. And the trend has been like steadily going up. We start to have better understanding of the risk factors. But for example, by the end of this year, we're expecting to have 67,000 new cases of pancreatic cancer, accounting around 3% of all new cases. But again, at the end of this year, we're expecting to have a 50,000 deaths, which is account about 80% of all cancer-related deaths. It's an aggressive cancer, and we call it silent killer because by the time the patient coming in, have some symptom from primary care physician and then referred to Dr. Dacha, for example, for diagnostic and all that, it's already stage 4. And 50% of the patient is coming to us with a stage 4 unresectable. Quarter of those can become regional disease. They present with regional disease, and maybe less than 15% coming in with resectable disease. The trend, been up, and we're going to talk a little bit about the risk factors. Mm-hmm. But, the 5-year survival rate for pancreatic cancer stage, all comers actually, is 13%. And for stage 4, it's only 3%. So every 100% coming in with stage 4, only 3 going to make it to 5 years. Aggressive cancer, we try to treat it with multiple modalities of target therapy. Immunotherapy didn't work well, and we try to treat it with chemotherapy. It's a systemic disease. But we said, okay, how we can prevent this disease, and if we can't treat it well, what risk factors? There's risk factors categorized in 2 categories. One is we can't prevent. We have control on those. Something like smoking, Dr. Dacha comment about smoking and having the risk factor for causing pancreatitis. That is also in addition to the 4,000 carcinogen in the cigarette. The other factor is metabolic syndrome, obesity, and a sedentary lifestyle. That also cause metabolic changes and insulin resistance, inflammatory changes. The diet is an important factor, not only for pancreatic cancer, but for all cancers. And we know that the processing meal, the processed meat, all these fast food is really like a risk factor. We don't know the cause, but there is more pro-inflammatory component to it. Other factor that is we have no control on is family history of cancer, which is mean there's something wrong in the genetic component. And especially if there is first-degree relative or 2 generation that we think, okay, well, there's a risk in the family. Genetic syndrome, like Lyme syndrome, BRCA, which is, we know it's a breast cancer risk factor or genetic changes. But now we know it is around 7% of the patient have a BRCA1 or 2, or a BRCAness related genes that can increase of risk of pancreatic cancer. Age by itself, just increasing age, that is put you in a risk category for having cancers. So there is modifiable and unmodifiable factors. And I think if we can't treat this disease well, and there is more promising treatment coming in the pipeline, right. But we better know the risk factor and maybe modify or adjust the one that is modified risk factors.
I want to move on to an issue that concerns all of you, and one I know that's very close to your heart, Dr. Gaber, and that's the issue of pancreatic cysts. And you recently launched a pancreatic cyst clinic here at Houston Methodist. Tell us a little bit about the clinic and tell us what the goals are and how we should be approaching these pancreatic cysts.
Well, really, I think the idea of the pancreatic cyst clinic was to get ahead of the pancreatic cancers. A lot of these cysts, not all of them, of course, but a lot of them do have malignant tendencies. And because they require very infrequent follow-up, the patients tend to ignore them after a while or not follow up with them. And there are different physicians referring them different places. So what we thought is to really centralize the care in the Underwood Center by creating this pancreatic cyst clinic. And I'm lucky to have the 2 people that are overseeing the clinic, Dr. Saharia and Dr. Dacha. So maybe, Ashish, you can tell us a little bit more about what you set up for the pancreatic cyst.
For me, I think the pancreatic cyst clinic started after I've started seeing so many patients who I know had pancreatic cysts and that developed into cancers because you can kind of tell based on the scans, and we have gone in and operated, and they've turned out to be inoperable. And so it's something that, I mean, if you look at just statistics, I would say about 7 to 10% pancreatic cancers do arise in pancreatic cysts, although only about 1% of pancreatic cysts will truly turn into cancers. But if we can find those people and have a systematic follow-up on the patients who've had pancreatic cysts, maybe we can prevent them from developing them. Of course, smoking, chronic pancreatitis, genetic disorders, we have little handle on them, but maybe we have a handle on these pancreatic cysts. And so that's why we started the clinic. And of course, there are guidelines, for us, the Kyoto guidelines that we tend to use in our clinic. We tend to focus a lot more on patients who have MCNs or on IPMNs, with larger sized pancreatic ducts or intramural nodules, etc. Or somebody's jaundice. We will definitely get worried if somebody's jaundice or their CA19-9 is high. We will get super worried about them. So the whole idea of starting a pancreatic cyst clinic is really, it's a stepping stone, honestly. That's what I look at as. And that way we can, we all know that pancreatic cancer is going to be the second largest killer after lung cancer by 2030. And that's a prediction. We can see it, and that's very little cure. And we have breast cancer, colon cancer, and lung cancers have ways to screen them, but pancreatic cancer does not. So we think that maybe we can use pancreatic cysts as a way to start this off, and then come up with some other unique ideas. And recently I was just reading about certain collaborations that people have done. They have collaborated together, and they have created ways to use AI to predict pancreatic cancers way ahead. And this is just an initiation. And what they're trying to do is find patients who have developed pancreatic cancer and see if they've had previous scans done in their lives, and get those scans done previous to development of cancer, and have at least 5,000 of those scans available, and put them through whatever models of AI that there are, and see if those models can predict that these patients would develop cancers. So it's just basically, so pancreatic cyst clinic, back to what I started off with, is a way for us to be able to do an early diagnosis of pancreatic cancer, if you would.
So Ashish, like if you want to go back, when we have those patients having genetic component, and
Right.
we think the high risk group,
That's true.
we tend to do like maybe an MRI of the abdomen annually, or EUS or ERCP on almost sometimes alternating MRI 1 year, the other
Right.
year. So for those cysts, and if there's like a solid component, what is your approach to those? Because I don't see those. I see them when they are cancer is diagnosed. In your clinic, what do you do?
If somebody has, so again, as you said, that if you have 2 family members who've had pancreatic cancer, I would screen all my all the family members for pancreatic cancers with a CAT scan, with a
Okay.
contrast enhanced CAT
You
scan,
do annual
annual scans.
scans. Okay.
And if you have like Lynch syndrome, BRCA mutations, Peutz Jeghers, all those patients will also need annual scanning.
No, but what about those cysts without any component of genetic component?
Oh.
The cyst, and you think that there's maybe a solid component, but it is not,
Solid
biopsiable.
component. No, if it has a solid component and it's 5 millimeters, then you will biopsy it.
Okay.
And Sunil,
Yeah.
you have a lot of advancement in terms of how you biopsy those. Tell us a little bit about it.
So when we are talking about aspirating the cysts or biopsying these mural nodules, so what we do is, again, we go by the Kyoto guidelines. Before we intervene on any of these pancreatic cysts, the pretest probability should be high. We go by the Kyoto guidelines, where the cyst is at least 3 centimeters, the pancreatic duct is dilated to at least 10 millimeters, there's a mural nodule at least greater than 5 millimeters, or the cyst size is growing rapidly, or the cyst is causing an obstructive jaundice. So first of all, for diagnostics, getting the CEA, amylase, or cytology, we use simple aspiration needles to get the fluid out. And sometimes if we need to biopsy the wall of the cyst, there is something called as a EUS, I won't take the name of the brands, but there is a biopsy needle where you can actually go into the cyst and take a biopsy of it. And more recently, what we have is confocal laser endomicroscopy guided approach. Actually, I was a part of a recent multi-center international study where we looked at inter-observer variability about how you would identify this cyst. And if you see across the board, there is a lot of patients that avoided a surgery when it was thought to be a pre-malignant, but confocal proved it to be otherwise. And some patients in whom it was thought to be benign proved to be the other way, and when they went for a surgery, it was found to be some form of a cancer. So in addition to it, molecular analysis is another way of going in the future. But unfortunate setback is there is a cutback from CMS paying for this procedure, so some of the commercial companies have closed. However, we do have certain institutions across the country that do molecular analysis, and the clinic that Ashish is running, Pancreatic Cyst Clinic, fortunately, we will be having some funding available so that we are actually able to do some more new studies trying to identify molecular markers that will predict cancer in the future in these cysts.
Yeah, we're hoping that we can, now that we have some funding, we should be able to send for molecular markers, because some studies have shown that doing molecular markers predicts development of pancreatic cancers to a very, very high degree, 90% or over. And obviously, nobody wants to operate on a pancreas and it turns out to be non-cancerous, and it's just painful because patients go through such a massive operation, and then we feel bad taking out the pancreas for just a cyst, and patients may have to go through complications. But obviously, at the same time, we don't want to miss somebody from developing cancer. So there's always this dilemma state that we run in. So we're hoping that with this new funding, we're able to get more molecular markers done for our patients.
Can you very important to do that, because there is a lot of data that's coming out that a lot of patients with the serous cysts, which are like never grow into cancers, are getting surgeries. Patients with IPMN, with simple IPMNs, are going for surgery. So that's why there is a growing need for improved diagnostics. And these focus more into expert centers so that patients get the right approach rather than sporadic care here and there. That's the whole reason why expert centers like the Pancreatic Cyst Clinics provide not just accurate diagnosis, but the right treatment for the right patients.
Do you see these markers really can differentiate between being a cancer or being a cyst associated with some pancreatitis? Because we always we think for the research we did for the last many years that how to differentiate between really a tumor marker for cancer, or this is maybe it's pancreatitis pre-cancerous but it's not cancer. If you want to does this have sensitivity and specificity?
Yes, very high sensitivity.
Oh, okay, so
well, tell us. I mean, one thing that we didn't mention, which I think will be important, is the advances in robotic surgery and how that affects pancreatic resections. All the hepatopancreatic biliary surgery that we're doing. How much do you think now are we doing robotically for these patients versus open surgeries, and how has that affected the outcomes?
Let me divide this into two parts. So one is the Whipple, that's pancreatic head, and the other one's body and tail. I mean, for body and tail, it's a no-brainer. Definitely robotic. Because the patients, we were doing all of this laparoscopically for years too, but with the advent of the robotics and our ability to do more fine work with a robot, I think we've been able to do a better job and more justice to these patients who have pancreatic body or tail cancers. But when it comes to Whipple's, pancreatic head cancers, and those patients, of course, if you have vascular involvement and you need to do vascular work, then you won't do it robotically. But for everything else, you would want to at least try to do it robotically. And those patients, with experts, people are able to get this done similar kind of time as they would do for open. But hospital stays are definitely less in patients who are going through robotic surgeries. And the outcomes are also almost exactly the same when you do robotic.
Well, I watched you guys, not a robotic surgeon, but I watched you do Whipple robotically. And I have to say I'm amazed at the ability to do that. So I think that's going to be a tremendous advance for our patients when they need. And I also, know of what you do endoscopically now, which we, was almost unimaginable years ago. So that's really good. You want to say something about what you do that way?
Yeah, for especially for the fluid collections related to pancreatitis, right? I can tell you, so I graduated 10 years ago, and even when I was about to graduate, the way we're doing things is different, and what we are doing now is completely different. And then we used to use some plastic stents to drain the fluid collection. I can tell you there's instances where I wheeled the patients to radiology because we caused bleeding from these, right? But now we have this new, what you call lumen opposing metal stents that have revolutionized how we take care of the pancreatic fluid collections. So for pseudocysts, it's still simple and straightforward. You can use the plastic stents or you can use the lumen opposing metal stents. What has really changed the paradigm is for the walled-off necrosis, because this is where we can use a larger caliber lumen opposing metal stents and try to avoid any surgery and try to get the necrosum out by endoscopy. However, it's not always possible. We should always go up with a step-up therapy to minimize the morbidity associated with the surgery itself. And the outcomes are much better in that way. However, these are not simple procedures like, even when you do by endoscopy, they are associated with very high risk of complications. And these are metal stents that tend to rub against the vasculature, can cause pseudoaneurysm in no time, and they bleed profusely. And the key thing that we always do is by endoscopic ultrasound, we look for vasculature in the vessels. And there are cases when I call Ashish and say, Ashish, there's a big blood vessel in this walled-off necrosis. And he tells me after the surgery, yeah, I opened it and I saw a big splenic artery there. I had to ligate that first before doing the ectosectomy. So think about if we were trying to do that by endoscopy, the catastrophic bleeding, right? So yes, there has been significant advancements, but the key important thing is trying to understand the limitations of endoscopy as well. If people don't look at their scans pre-procedure, try to take time looking into this walled-off necroses by EUS scanning for blood vessels or pseudoaneurysms, then it's easy to land into trouble. So yes, we have made advancements, but there is definitely a cautious approach.
And the number of open procedures or cyst gastrostomies or cyst jejunostomies that we used to do has gone down significantly. I mean, I'm not
Dr.
complaining, but I'm just
Daka's
saying,
doing them without us, yes.
So we do quite a few of them actually. So
Yeah.
The bottom line that I'm hearing from all of you, and all of you, including Dr. Gaber, are pancreatic experts except me, so I'm the observer. But what I'm hearing is that a team approach here is absolutely fundamental.
Absolutely.
And what I'm hearing also is that here at Houston Methodist, whether it's on the endoscopic side or the surgical side or the oncology side, there are people who are working very closely together to evaluate these patients, to provide them with optimal therapy, and hopefully to give them a better outlook. To finish off, I'd just like each of you to mention something that you've heard about that's coming down the pike that may change the outlook for patients with pancreatitis or pancreatic cancer. Sunil, any new things that you're hearing about?
So as an advanced endoscopist, one of the most dreaded complications we worry about is post-ERCP pancreatitis. And talking to experts across the country, so one of the exciting things that's coming up is there is a thought process that tacrolimus can significantly decrease acute pancreatitis after ERCP, kind of similar lines to how we see in post-transplant patients. And I'm sure there are tons of other advanced endoscopists across the country so excited about that news. But that would be one important thing that I would be look forward, because of all the procedures we do, ERCP is the one that will humble you in an unknown scenario. So you can be an expert, but you cannot escape a post-ERCP pancreatitis. So to me, that would be one of the most exciting developments that I'm looking forward for.
So Ashish, it sounds like they're stealing one of your drugs now, and not only your patients.
Go for it. If it helps them, yeah.
So what in terms of, you've invested a lot of time and effort in this pancreatic cyst clinic and in pancreatic surgery. So anything exciting from the surgical side? You mentioned robotics. Anything else?
Yeah, robotics is definitely there. But if you give me since you've given me this chance, and I have a sort of a wish list of what I would want to do or would hope that we're able to do it as an institution, is to be able to institute a plan. And I've thought about it a lot because payments is an issue and whatnot. I hope and wish that every CT scan that gets done in Methodist emergency rooms, they at least look at the pancreas and make at least a comment on what the pancreatic duct looks like and the bile duct looks like, and just to say, just as a screening tool for starting for pancreatic cancers. I know they do it for lung cancers,
yes,
but I don't know if we can ever get reimbursements for it, and that's usually the driver for all these scans that we get done. So that is my wish list. And the second wish list that I have is that we are able to get a structure of people who can sit down and do radiomics, and we have AI that can actually, we can feed data into AI, scans into AI, and be able to predict patients who are likely to develop pancreatic cancers.
That's a fantastic
Yeah.
thought, because of course CT is a digital image,
Right.
so it should be possible to do that. Now, the AI might just be the tool to get that for us.
Well, even though like pancreatic cancer is aggressive, but there's light at the end of the tunnel. And there's two things I'm excited about. One is born and raised in Methodist here, actually a drug we are repurposed to be used on pancreatic cancer. And actually speaking of the pancreatitis and precancerous lesion. So we've been working on research that is where identified transcription factors actually can lead to pancreatic cancer. And this transcription factor is high when we are infant, turned down when we are adult, and turn on again in pancreatic cancer and other cancer. So this transcription factor is a prognostic factor. It's bad when we have it high, but it's also a drug target. And we have now a drug repurposed for migraine medication. It's now going to be in phase 1 soon at Methodist, where we're going to use to target pancreatic cancer by targeting the transcription factor that's lead to early stage pancreatic cancer. And that is what we know. This disease we treated with systemic chemotherapy for a decade. And now to go for targeted therapy is exciting. So this is one we are excited about from Methodist in research and outcome in phase 1. The other exciting part, which is globally, they are transcription factor, or not transcription factor, rather oncological factors like KRAS. KRAS for ages, we know that 90% of cancer, of pancreatic cancer, have KRAS mutation.
Right.
And this been an oncogenic factors. We thought that it's okay, well, this is nothing to do about it. It's not actionable, rather. Till the last few years, now we have targets for KRAS. And KRAS is not one type, it's KRAS G12V,
G12V.
D, and C. And now we're talking about changing from chemotherapy to treat pancreatic cancer to targeted therapy.
Yeah.
So this is exciting. This is actually the most exciting time for the history of pancreatic cancer, is now we have more drug over the last couple of years, more than the last 20 to 30 years, just targeted therapy. So exciting, and we're expecting to see
KRAS
more.
and the BRCA drugs also.
Yeah. So this is where we are shifting gear.
Yeah.
It's not only chemotherapy. Now we can switch to targeted therapy. So we're excited about that, even though the outcome for such a disease was been aggressive.
Well, really, everything they said is much more exciting than what I have, because one of the things we didn't talk about is really chronic pancreatitis and autoislet transplantation. And I think there are lots coming up in that field with the stem cell therapies and, really putting back so that you don't have people with chronic pancreatitis have a lot of problems. The other thing that I think is really exciting to me, and I think it's exciting to you too, we've talked about that in the Underwood, is we are going to start a surgical AI fellowship in June. And I think, Ashish, you get a chance to pitch your project to be the first thing for those fellows to work on, is to look at acute pancreatitis, pancreatic tumors and so forth, because we're looking at the lung nodules, and now we can look at pancreatic tissues with AI. I think that would be a really good project.
And that fits in very nicely with what was just launched, you and I launched last week with the Rice University, namely the Underwood Digital Health Initiative project.
Right. That's why I thought you're going to like it a lot.
Yes, I really love that. So, look, it's been a great conversation. I think it was wonderful that we ended on a positive note, and there were lots of positive notes, which was fantastic. And I think a lot of exciting things to look forward to. I'd like to thank my co-moderator, and I'd like to thank each of our panelists. I think it's been a great discussion. Thank you all very much.
Thank you.
Thank you.